Uh, Good morning. Today we will have a case discussion on anterior-abdominal mass. Dr. Aditi Singh, who is the second year junior resident at Howrah District Hospital, will present the case. So Aditi, can share your screen and present?
Yes, sir. I'm
Okay.
Good morning, sir. My case presentation is on desmoid tumor of lower abdominal wall. Mrs. Savita Pandey, 36-year-old female from Delhi, housewife, presented to the surgery OPD. Chief complaint is swelling in the lower abdomen since last 2 years. History of presenting illness. The patient was apparently well 2 years ago when she noticed a swelling in the lower abdomen of about 2 into 2 centimeter size. Insidious in onset, the swelling has grown in last 6 months rapidly to attain the present size of about 7 into 7 centimeters. She complains of a dull aching pain over the swelling on and off since last 6 months. No history of loss of appetite or weight loss. No history of loss of consciousness. No history of respiratory distress. Past history, no medical illness in past, no history of any surgery, no history of any irradiation. Personal history, menarche at 12 years, regular menstrual cycle, married at age of 24, 2 children. There is a past history of cesarean section for the children. Family history. No history of similar disease in family. Mother and father both alive and healthy. Dietary history mixed. Allergy, non-allergic to any known substances. Treatment history, no history of any treatment. Addiction, no history of smoking or alcohol intake. Physical examination. Patient was...
Wait, Aditi.
Yes.
Wait, we'll discuss the history part. Huh?
Yes.
Go back to the history slide. Yeah, history of present illness, fine. Don't get biased with the heading given to you. Okay, so the heading was discussion about the abdominal mass. So history of present illness, you keep in mind that history of illness is a very important area of your case presentation. And if you start with the presentation, she has got a swelling in the lower abdomen, and you can specify either in the right lower half of the abdomen, left, or the central part of the abdomen. So this will give an idea where the swelling has started, number one. And then you have described the progression. So don't be biased with the desmoid, the heading you made. I am concerned about the swelling in the abdomen. That's it. He noticed the swelling. So this swelling may be parietal swelling. This may be intra-abdominal swelling. This may be retroperitoneal swelling. So the next thing will be to find out what other symptom patient had, and then try to make out the swelling is from which tissue of origin. And then we can examine the patient, come to diagnosis. So looking at the history, what do you think? So where is the swelling exactly? Is the right lower half in the iliac fossa region, or in the central part in the hypogastric region or umbilical region? That is important.
Yes, sir. Sir, in hypogastric...
Can it be a colonic mass?
Sir, it's a chronic mass.
Can it be a colonic mass?
Colonic, no.
From the history. Yes, why not? Can it be a pelvic mass arising from the ovary or from the uterus?
Yes, sir.
So my history will cover the symptoms pertaining to all other abdominal pathology. So you started with history of loss of appetite or weight loss. Okay, can it be a gastrointestinal tumor? If there is a very large gastrointestinal tumor or any other abdominal tumor which can compress the outlet obstruction.
Yes.
So your job in this situation will be go to each of the system, ask questions, and even if it is negative, you keep on describing that. So what other GI symptom you would ask this patient? And at the end of which you can say it is unlikely to be a chronic mass. A mass which is palpable, which is 7 by 7 centimeter, if it is a chronic mass, patient will have some GI symptoms.
Sir,
So
we
instead
take
of
the
describing only 3 points, you come to the GI. It can be kidney mass.
yes,
It
sir.
can be mass in the kidney, which is a pelvic kidney or a drop-down kidney. So
Yes, sir.
you try to describe the whole of the symptoms, like you have said, no history of loss of appetite, loss of weight. Then describe whether she has got any sensation of fullness after meals, any nausea, vomiting. No. No sensation of fullness after meals, no nausea, no vomiting. That exclude that there is no gastric outer obstruction.
Yes, sir.
Then you mention about pain abdomen. That is very important. Patient who has got a swelling and the swelling is rapidly increasing in size, that swelling, if it is a capsulated swelling, can cause pain because of capsular stretch. If it is not a capsulated swelling, the swelling is infiltrated into the local structures, may cause some amount of dalek pain. So that point has to be mentioned, whether she has got any pain or not. If patient has got pain in the abdomen, you have to describe the character, duration, periodicity, relation of pain to food, or relation to pain to defecation. Okay, pain abdomen.
Yes, sir.
Next is bowel habit is important. Bowel habit. What was our bowel habit before the illness started 2 years back? What is the bowel habit at the moment? Any history of passage of blood and mucus to stool? Okay. Any
Yes,
history of hematemesis or melena?
okay, sir.
That covers your GI part. Next, urinary. Any loin pain, any history of hematuria, any lower intestinal obstruction syndrome. That means frequency of micturition, any difficulty in passing urine. So what I'm trying to say is, if you describe all the symptom history of present illness, at the end you can say, yes, this patient does not have any other symptom
Yes, sir.
pertaining to each of these underlying organs. So it is unlikely to be arising from the organs. So it is more likely it is from the peritis, or it may be a retroperitoneal mass. Okay. And then if you suspect that this is a malignant mass, in that case, you have to exclude whether patient has got any symptom pending metastasis. You have written one line, no respiratory distress. Instead of this, you can write, patient has no symptom suggestive of distant metastasis. What does it include? If you use this line, patient has no symptom suggestive of distant metastasis. If I suspect a sarcoma in the abdomen,
Yes, sir.
swelling in the abdomen, rapid growth over a period of 6 months, it can be a sarcoma. So if you use this line, patient has no symptoms suggestive of metastasis, what all you have asked? Abdomen, patient may have abdominal distension, patient
Yes,
may
sir.
have jaundice. Respiratory, patient may have chest pain, patient may have cough, hemoptysis, respiratory distress. Patient may have neural symptoms like, you see, only loss of consciousness is not the symptom of cerebral metastasis. Symptoms of cerebral metastasis may be first symptoms due to increased ICT, like headache,
Yes, sir.
vomiting, blurring of vision. And then if the metastasis deposits in a particular area of the brain, that can cause focal neurological deficit, like weakness of any of the limbs, okay, any sensory loss. So you have to point these specific symptoms. A sarcoma may metastasize to the bones. Patient may have recent onset of low backache. Patient may have aches and pain in the long bones. Okay.
Yes, sir.
So you see, you have finished up history of illness in about 6-7 lines. I would expect history of illness to be at least in 2-3 paragraphs. The first paragraph is about elaboration of acute complaint. Next paragraph is to ask about the symptom pertaining to each of these systems inside the abdomen.
Yes, sir.
And third will be symptom which will suggest patient has got any distant metastasis or not. You can write that, but when you describe, you can say one line. Patient has no, you can write everything. no chest pain, cough, hemoptysis, no history of abdominal distension, no jaundice, no history of loss of consciousness, no headache, no convulsion, no focal neurological deficit, no recent onset of low backache, no extent pain in the limbs. So, if you write this and say in one line, there is no symptom suggestive of distant metastasis. That includes all your points. Clear? So,
Yes,
try to be very wide open at the beginning. At the beginning, don't get biased with the diagnosis. You approach the patient that the patient has got a lump and take other history so that at the end of history or examination, you can bring out points to justify the diagnosis. Next, past history. And you see, this, go back. Patient who has got a suspected desmoid tumor,
yes,
it is said that, is it common in men or women?
it's more in sporadic cases. It's more common in female. In familial cases, it's
And
equal.
what is the usual history? What is the usual history where is a scenario for a desmoid tumor to develop?
She'll
This
have
can happen following. This can happen following pregnancy.
Yes, sir.
This can happen following some surgical trauma.
Yes, sir.
Okay, so this patient has 2 cesarean section.
Yes, sir.
And 36 years, maybe that second, it gives specifically when is the second cesarean section done. It may be that if the second cesarean is about 2, 3, 4 years back, then this trauma of surgery may be one producing factor for development of this desmoid tumor in the abdominal wall. I am not concerned with desmoid at the beginning. I am concerned about different history part, which might help me in coming to a diagnosis at the end of my history and examination. Okay, past history. Why do you say no history of any surgery? You are saying patient for cesarean section. There is surgery.
Yes, sir. That's
my point.
I had to correct it.
Patient has no major medical. You see, some people may have minor medical ailment. So the point to mention is patient has no major medical ailment in the past.
Okay.
Okay. She underwent 2 cesarean section. The first one this year back, second one this year back. And if you find this onset of this tumor is very close to the second cesarean section, you can say that following cesarean section, within 6 months, she noticed the swelling in the lower abdomen. Okay. And then mention here about the comorbidities, whether she is a known hypertensive or diabetic or any other comorbidities. Okay. Personal history. Personally, it doesn't start with menarche. Try to understand. If you are giving a good description for history, that is important. For DNB, it will be allowed to narrate the history in about 8-10 minutes. So, personally, study the marital status. Patient is married. Patient has 2 children. Then mention about the dietary habit, any addiction, and then describe the menstrual history, and then the obstetrical history. Why did you ask similar disease in the family? Does a desmoid tumor has any relevance to the family history?
Sir, no, sir. Maybe for in TAP syndrome, family.
Wrong word. I asked you whether family history is important in a patient who's got desmoid tumor. Yes or no? Is family history important?
Yes, sir.
What do you say? Yes or no?
Yes, sir.
Why? Why is family history important in a patient where you suspect a diagnosis of desmoid tumor?
If it's familial desmoid tumor, then it's
yes, like name some situations.
The FAP,
Tumor
familial adenomatosis polyposis. Familial adenomatous polyposis syndrome.
So, if you have other family members having familial adenomatous polyposis,
yes, sir,
which is because of mutation in which gene?
APC gene.
APC gene. So, patient having other family members having history of familial polyposis or carcinoma colon,
yes, sir,
may have desmoid tumors, number yes, 1. Yes. And another variety of this APC gene mutation is Gardner syndrome. What is that?
Gardner syndrome includes
APC gene mutation with some extra-intestinal manifestations.
Yes, sir. Desmoid tumor and osteomas.
Desmoid tumor and osteomas. So the family history is important because you're trying to find out whether patient family member has other manifestations like polyposis coli, carcinoma colon, or any other features of Gardner syndrome.
Yes.
Okay.
Yes,
Dietary
sir.
habit does not come after family history. As I say, dietary habit goes to your personal history. Okay.
Okay.
Treatment history. At the end, if you find the patient has underwent some imaging, patient might have underwent a two-cut biopsy. These are the
Okay.
things you mentioned here. Got my point? If patient in the
Okay.
exam hall
Yes, sir.
and patient is admitted for surgery, patient may have some investigation being done already. So you can say that patient underwent some investigations, patient underwent a biopsy and some imaging investigation. You need not say the report, but no history of any treatment is very unlikely. Patient who is admitted for exam, patient has some form of investigation being done. It's unlikely that patient has come to OPD to straight to exam hall. Okay.
Yes, sir.
Addiction history again goes to personal history. Okay, so make the history more, make a habit for any patient. For any patient you are present in the examination, make a habit of including in the history of present illness, GI symptoms, respiratory symptom, cardiovascular symptoms, neural symptom, genitourinary symptom, and skeletal symptoms. If you have these few things clear in your mind, you can face any case in the examination. So always keep in mind that whatever the case is, you keep on asking this question. You may not be present in it. Like for a hernia, you will not be talking of no history of chest pain, calf hemoptysis, or convulsion. But what I'm trying to say is, even in a hernia, I will ask these questions. Because an elderly patient, hernia may have a underlying malignant disease. But I may not give emphasis to these points. What I'm trying to say, you elaborate all these symptoms.
Yes, sir.
Next. Next.
Patient was examined with proper consent in a well-lit room. General survey. Patient was alert, conscious, and cooperative, oriented to time, place, person. ECOG performance status is 1. Built average, well nourished. No pallor, icterus, cyanosis, clubbing. No lymphadenopathy. No pedal edema. Patient vitals, when I examined the patient, pulse 90 per minute, regular in right radial artery, no radial or radiofemoral delay, blood pressure 110 by 60 mmHg, measured over the right brachial artery in supine position, respiratory rate 20 per minute. Local examination on inspection, about 7 into 7 centimeter swelling in hypogastrium and right iliac fossa. Surface appears irregular. Margin appears well defined. There is no pigmentation over the skin, no venous prominence, no impulse on cuffing over the swelling. Umbilicus slightly pushed upward. The swelling becomes more prominent on leg raising test. On palpation, temperature over the swelling is normal, no tenderness. 7 into 7 centimeter swelling in hypogastrium and right iliac fossa, a regular surface with well-defined margins, form and consistency, not fixed to the overlying skin or underlying structures, no cough impulse, no fluctuation, no transillumination, no pulsation over the swelling. On percussion, dull, no auscultation, no bruit heard. Systemic examination. Nervous system within normal limits. Respiratory system. Bilateral air entry equal. No added sound heard. Cardiovascular system. S1, S2 normal. No murmur. Bowel and bladder habits normal. CR examination. No growth. No bleeding. Examination of cranium and spine normal. Summary. Savita Pandey, 36-year-old lady, presented with a swelling in her lower abdomen for last 2 years. The swelling was initially insidious in onset with a size of 2 into 2 centimeters, but for the last 6 months, the swelling has increased rapidly to attain the present size of 7 into 7 centimeters. She complains of dull aching pain over the swelling for last 6 months. She has no other complaint. The swelling is firm in consistency in hypogastrium region and parietal in origin as evident by the leg raising test. Surface is irregular, margin well defined, mobile, and free from the overlying skin. Liver and spleen are not palpable. There is no other mass in the abdomen. Uh, the provisional diagnosis, this is a case of anterior abdominal wall swelling.
Aditi, there is a lot of scope for improvement in the presentation. Okay. So go back to the physical examination part. Yeah, when you start presenting, if you keep on reading this whole part of general survey, you waste 3 minutes time because you have fixed time for presentation. So if you have written your paper, these all the points, when you start presenting on physical examination, general survey is essentially normal. Her vitals being stable. That's it, finish.
Okay.
You need not keep saying all these points because it takes you 2 minutes out. So general survey is essentially normal. Her vitals are stable. Go to the next part. Don't get biased only the swelling. What you have done in the local examination, you have described the swelling only. This is swelling in the abdomen. I have taken the details history about all the organs in the abdomen to find out whether that is at fault or not. So your examination here is not examination of swelling. Try to understand. You are doing a local examination. Your heading should be examination of abdomen. Got my point?
Okay.
Here the patient came with a swelling in the abdomen. It can be till this time you are not sure it's parietal, it's intra-abdominal or retroperitoneal.
Yes.
Up to this point, you are facing a patient who are having abdominal swelling. And symptom-wise, there is no bowel symptom, there is no urinary symptom, there is no menstrual irregularity. Okay? And no symptom of distant metastasis. That is your impression at the end of history. Now, coming to abdominal examination, how do you start? If you start the inspection, patient is in front of you. Patient has got a swelling in the hypogastric and right iliac fossa region. So your examination start with the examination abdomen, shape of abdomen. If there is a bulge in the lower abdomen, you can describe the abdomen is asymmetric with a bulge in the lower abdomen. 7 centimeter swelling probably will be seen from surface if it is a parietal swelling. So first your examination starts with shape of abdomen and symmetry. Okay, you describe the abdominal shape. Is the flank full? Next point is any swelling seen in the abdomen. Comment about the umbilicus. A lower abdominal swelling can push the umbilicus up or make the umbilicus flush with the surface or invert it. So inspection of the abdomen, shape and contour of the abdomen, any asymmetry, umbilicus. Describe the skin of the abdomen. You understand what I'm trying to say.
Yes,
you are examining patient abdomen, not the swelling. Then comment about the skin of the swelling of the abdomen. Any pigmentation. You find there are 2 scars, you cannot ignore that. Patient has got a cesarean section, either a phalangeal scar or midline scar, whatever scar is there. Okay, and comment about the scar, whether there is a scar hypertrophy, any keloid in the scar or not. Okay. Any venous prominences. Some patient having a sarcoma in the abdominal wall may have venous prominences. Then come to the swelling. If you find a swelling in the lower abdomen, what are the things you start describing? You see, you first don't start the swelling size. How do you describe abdominal swelling? So now you find there is a swelling in the hypogastric and iliac fossa. How do you start the swelling description? The first to describe the position and extent of the swelling. So if you take the position in abdomen, there are different regions, or you can say quadrants. Since the swelling in 2-3 regions, which is the primary region where the swelling is located? How do you decide? Got my point? Swelling in the hypogastrium, right iliac fossa, maybe in the left iliac fossa. So where is the swelling? I will describe the swelling in one region, and I will say the swelling extend to the left on this region, on the right above this. The center of the swelling. You consider the center of the swelling as a primary location. If you find the center of the swelling in the right iliac fossa, you say the swelling is in the right iliac fossa, extending to the left iliac fossa, ascending above to the umbilical and lumbar region. So you have to have an idea. In the paper, if you draw a picture of abdominal areas and mark the swelling so that you can make out where the swelling is. So first to describe is the position and extent of the swelling, number one. Next, you assess the shape and size. If you can see, all swelling in the abdomen may not be obvious on inspection. Most of the time, the swelling margins are not very well delineated. In that case, you can describe a fullness. And don't try to elicit respiratory movement in a patient who has got a swelling in the hypogastria or in the iliac fossa. You need not mention that point. You have not mentioned, good. But many people mention no mobility to respiration. It's not required to be mentioned. Then you describe the surface and the margin. You see, a swelling in the abdominal wall with a peritis, it is unlikely the margin will be well defined on inspection. Very difficult to make out. So patient will be in front of you. And if you cannot corroborate your finding on real time with the examiner, then you will have a problem with the clinical examination. Okay? Then examine the hernial sites.
Yes.
Now come to palpation. When you come to palpation, how do you start? You have studied the temperature of the swelling. I am concerned with the temperature of the abdomen as a whole. Any area of tenderness. It's not the swelling I'm examining. My examination of the swelling is part of my abdominal examination. So I'll examine the other part of the abdomen and then the swelling itself. And if you have a swelling which is firm in feel, how do you expect it will be probability of fluctuation or tension diminution? You should not mention at all. You see, all points are not to be mentioned everywhere. You have common swelling is firm in consistency. And don't get biased that all Desmoid tumor will become prominent on leg rising test. What does it mean? Suppose the swelling is getting more prominent on leg rising.
Yes, sir.
What is the plane of the tumor? Where is the tumor arising from?
Sir, because it is in parietal layer of
Parietal means what? You see, the whole layers of the abdominal wall is a parietis.
Yes,
if you study the skin, subcutaneous tissue, anterrectus sheath, rectus muscle, posterior rectus sheath, peritoneum, the whole thing is a parietis. Suppose the swelling is arising from the rectus muscle itself or from the posterior rectus sheath. What will happen is when leg rising?
So it won't get prominent.
Yes. It may remain same. It may not become less prominent.
Yes, sir.
But a swelling which is arising from the anterrectus sheath or from the subcutaneous tissue will become more prominent. So you apply this concept to your real-time patient examination. You see what is happening to the patient. It is not necessary that all parietals will become prominent. A swelling arising from the rectus muscle itself or posterior rectus sheath may not become more prominent on leg rising test. But still it will be a parietal swelling, because internal swelling may become less prominent. How will you ascertain, say, intraperitoneal or retroperitoneal swelling?
So we'll put the patient in knee elbow position.
No, that is the thing I'm trying to say. You see, you listen to any of this RRC or whatever. This has been discussed time and again. In exam, don't make the patient knee elbow for any reason. It's a very awkward position for the patient and it's difficult for the examiner to examine also. So don't mention anything about the knee elbow position.
Okay, sir.
This is now described as lateral tilt test. Okay. You are feeling that swelling in the hypogastria and the right iliac fossa. And you have decided that swelling is not getting prominent on examination. Okay. If it's prominent, it's parietis. No question of asking for lateral tilt test to ascertain retroperitoneal. Only when swelling is getting less prominent, that suggestion is intraabdominal swelling. In that case, you need to ascertain the retroperitoneal knot. In that case, instead of knee elbow position, you say, I'll do lateral tilt test. You ask the patient to turn to the left side. Intraabdominal swelling may shift to the other side. Okay, irritable tumor will not shift. So that is lateral tilt test. So for a firm swelling, don't mention about fluctuation or translumination. And in the same palpation, you try to find out any liver palpation. Liver is palpable or not, spleen is palpable or not, any other mass in the abdomen. And the same go next. Percussion. Dull on percussion, whole abdomen is dull. Probably you are confining your exam only to the swelling itself. What I'm trying to say is you examine the abdomen as a whole.
Yes, sir.
Percussion, normal timpani note in the abdomen. The area over the swelling appears dull. No bruise about the swelling. Normal bowel sounds are audible. Parietal examination and parvaginal examination, you can say not done, or if you're done, you can exclude that whether there is any pelvic origin of this mass or not. Okay. And again, the system examination. You can state with bladder and bowel habit normal doesn't come in system examination. PR examination goes to abdominal examination because this is a primarily abdominal case. Summary. Next slide. Yeah, summary should be also be good. As I always say that there will be 2 paragraphs in the summary. This summary of the patient tells you about the swelling itself. And then if you have mentioned clearly, as I said, the cesarean section, pregnancy has got some bearing on development of desmoid tumors. That point should have come. Patient underwent 2 cesarean sections. First on this, second on this. And rightly mentioned that she has no other complaint. Again, you are examining the swelling is forming. No. On physical examination, general survey is essentially normal. On abdominal examination, abdomen appears asymmetric with fullness in the lower abdomen. And there is a swelling located in the right iliac fossa, extending to the hypogastrium and the left iliac fossa region. The swelling is parietal in origin, as evident by leg rising test. Surface irregular, margins are well defined, mobile. Is the swelling fixed to the abdominal wall muscles? How do I ascertain? You said free from overlying skin. Is it fixed to the underlying abdominal parietal structures? How do I ascertain that?
So we'll move the swelling over the along the direction of the muscle and perpendicular to the direction.
You see, if the swelling in the iliac fossa and the hypogastric region, the direction of muscles are different here.
Yes, sir.
You have tried to understand the anatomy here. You have anterectus sheath.
Yes, sir.
You have rectus muscle vertically going up.
Yes,
and then you have the strap muscles, these abdominal flat muscles.
Yes, sir.
Which are coming mostly obliquely here.
Obliquely. Yes.
So here your job is to find out whether the swelling is freely mobile from the skin, something on the parietal wall,
Yes, sir.
or there is some fixity. So how do you test for that? What you ask the patient to do and what you do. Remove the swelling. You say the swelling is mobile.
Yes.
If the swelling is mobile, that means the swelling has not invaded into the posterior abdominal wall. Got my point?
Okay.
Some tumors are very aggressive.
Yes,
From abdominal wall, this can invade the abdominal cavity and then can go to the retroperitoneum. If the swelling of the retroperitoneum, it will be immobile. Without any maneuver, you try to move the swelling is immobile. That indicates that the swelling has invaded to the retroperitoneum. Okay, number 1. Number 2, you try to move the swelling is mobile. How do you make the abdominal muscle taut?
So by asking the patient to head up.
Head up, lower abdominal swelling, make the patient leg up.
Leg up.
When the patient make leg up or head up, the flat muscle abdominal get taut, rectus get taut.
Yes.
Now you try to move the swelling. You have tested the swelling mobility with the muscle being relaxed, and now you make the muscle taut and try to move again. If you find the swelling now getting restricted mobility, it is very likely patient who has got a large desmoid tumor, there is a possibility of some fixity of the swelling to the rectus sheath or to the strap muscle, the flat muscle of the abdomen. So test for that. The method for testing is test mobility in relaxed state and test mobility of the muscle contracted. Okay.
Okay.
Anti-abdominal swelling may not be a clinical diagnosis. At the end of this, we have described so many things.
Yes, sir.
At the end of this, I can give a diagnosis. At least you should be try to give what if I ask you to give a diagnosis, what diagnosis you put forward in this patient? First of all, you have settled that this is a intra-abdominal parietal swelling. What?
It's in parietal swelling.
Parietal swelling, number one. Number two, if you see the history, it's a swelling occurring in a female patient who underwent 2 cesarean sections.
Yes, sir.
And there is a history of rapid increase.
Yes, sir.
So would you put a lipoma in this patient?
No, sir.
No.
No.
Would you put a soft tissue sarcoma arising from this abdominal wall? Is it more common? Which
No,
is more
sir.
common?
Desmoid tumor is more common. It has a history of.
So you can, with this, you see, you cannot suddenly say desmoid tumor unless you have this history of a patient who has got 2 cesarean section.
Yes, sir.
Following this, the swelling is coming up and rapidly increasing in size.
Yes, sir.
She has no other complaint. You see, patient has no bowel complaint. I exclude colon. Patient has no urinary symptom.
Yes.
And on examination finds a parietal swelling. So in that case, you can say, sir, as desmoid tumor is common in females,
Yes.
and this often happens in patient after pregnancy or cesarean section, this is
Yes.
likely to be a desmoid tumor in the lower abdomen. Okay, instead of putting a DD, what did you like to put in this patient? Suppose next.
Sir,
I said this is a desmoid tumor. I'll ask you why desmoid tumor next. But what DD you can put forward?
Soft tissue sarcoma.
But you should say that low grade soft tissue sarcoma.
Low grade, okay.
It should say low grade soft tissue sarcoma. Okay, yes, soft tissue sarcoma is another possibility. What else?
The lipoma.
Lipoma I cannot put. How can you put lipoma? You say it is irregular swelling, okay, farming consistency, rapid increase. You put something which is a locally malignant tumor or a malignant tumor. You cannot put lipoma. No. You see, you need not put a long list of diagnoses. Your idea is to putting is a swelling arising from the parietis and then a rapid increase size. So a low grade soft tissue sarcoma, that includes everything. If you say soft tissue sarcoma, it includes fibrosarcoma, it includes rhabdomyosarcoma, hemangiosarcoma. So all sarcomas are grouped in this group. So these are the two important diagnoses. Why do you say it's a desmoid tumor? First of all, if I ask, what is a desmoid tumor?
The desmoid tumor is a mesenchymal neoplasm, a locally aggressive tumor.
Try to define a desmoid tumor. Desmoid tumor arises from which tissue?
Sir.
It arises from the musculoaponeurotic tissue.
Okay. Yes, sir. Muscular.
Desmoid tumor arises from the musculoaponeurotic tissues.
Yes.
These are usually deep-seated tumors. It's not a subcutaneous tumor. These are usually deep-seated tumors and characterized by locally aggressive behavior.
Locally aggressive.
Do they metastasize?
So they don't metastasize, but the recurrence rate is high.
No, that is not metastasis. I'm trying to say is
the
behavior of the desmoid tumors they are deep-seated tumors.
Yes, sir.
They arise from the musculoaponeurotic layers, mostly myofibroblast. These are myofibroblasts from which these tumors are arising.
Yes, sir.
These are locally aggressive. They can infiltrate into the local structures.
Yes, sir.
But this tumor usually does not metastasize to the distant site.
Yes, sir.
Okay?
Yes, sir.
What is the natural history of desmoid tumor? Suppose you have a good number of patients who are not being treated. If you follow this patient up, what is the usual natural history of desmoid tumors?
So it grows over time, but may regress in some cases.
First of all, it can grow.
Yes, sir.
That is one important behavior. These desmoid tumors may keep on growing. Second possibility is these desmoid tumors may get stabilized, that they have grown to some extent and then remain stabilized, doesn't go further. Third is there is some incidences of regression of these desmoid tumors, spontaneous regression, although very rare. So this is the basic natural history. These tumor can progress, these tumor can get stabilized, or there are some rare incidences where the swelling has shown some regression. Okay?
Yes, sir.
So this is the patient where you have diagnosed this isolated desmoid tumor. How do you approach this patient? How are you going to approach this patient?
So I will do the routine workup of patient and
Don't say that. It's MS
investigate.
exam. MS
Hello.
and I will do some investigation to assess the patient fitness for say, because here we know the distance staging. If my diagnosis is desmoid tumor, there is no question of asking for a CT of chest or bone scan. No.
Yes, sir.
Okay. So
I-
here my idea is to confirm the diagnosis.
Yes, sir. By
So
USG
don't say
and
routine. For any,
MRI.
you say, for any of your case in the exam,
Yes, sir.
for approach to the patient, you always say, if it's a malignant disease, diagnosis to be confirmed, we need some investigation for confirmation diagnosis. Number two, investigation to stage the disease. And number three, investigation to assess the patient fitness for anesthesia and surgery. So here I like to confirm a diagnosis. So what are you going to do?
To confirm my diagnosis, I'll do the USG of abdomen and MRI of the.
Don't in one line. First, wait. We'll do USG.
Yes, sir.
How USG will help you in this patient? How USG is going to help you in this patient?
Sir, it will tell if the swelling is cystic or solid.
Swelling is cystic or solid. Number one, ultrasound can make out whether swelling arises from the parietis,
yes, sir.
whether swelling is intra-abdominal or swelling is retroperitoneal. Ultrasound of the abdominal part will give an idea whether the patient has got any other intra-abdominal pathology.
Yes, sir.
Okay, you can see the kidneys position. You can see any swelling arising from the pelvic structures like uterus or adnexal structures. So ultrasound is a very good investigation for giving a primary assessment. But is it all for assessing a suspected desmoid tumor?
No, sir, I'll do MRI also.
Because you need to do some imaging, axial imaging, by which you can assess the exact relation to the swelling to the adjacent structures and extent of the tumor. So you can say MR straight away. Okay, CT and MRI both are helpful, but for soft tissue swelling abdominal wall, MR is better than CT.
Yes, sir.
So you can say how MRI is going to help you in this patient.
It will help me. It will detail about the adjacent
Use a particular
structure.
term. These gives you exact delineation. Ultrasound cannot give an exact delineation of the tumor.
Yes, sir.
In MR picture, you can make out the exact delineation of the tumor. Okay? Is origin, is extent to the local tissues, infiltration. Okay? So MRI give you an exact delineation of the tumor cell. You have axial cuts, you have vertical cuts also. So you can make out the relation of swelling to the vital structures. What else? You have done MR, you have done ultrasound. What next?
So then I do the test to stage up the disease.
So you are not sure yet is desmoid or is a sarcoma. Treatment will vary.
Yes,
there is a
the
role
core
for
needle biopsy we can do.
yes, there is a role for doing a biopsy. What biopsy is going to do?
Core needle biopsy.
What? Blind connected? You will do it in the what?
No, sir. No, sir. MRI, CT scan guided or USG guided.
USG guided can do. So for confirmed diagnosis of desmoid tumor,
Yes, sir.
ultrasound, MRI, and US guided to cut biopsy.
Yes, sir.
For diagnosis. So we got a diagnosis from the to cut biopsy. It's likely to be desmoid tumor.
Okay.
And histological characteristics of this tumor, you can mention
Sorry, sir.
few histological characteristics of desmoid tumor. Histological characteristics on to cut biopsy.
Okay. So it's histological features.
Yeah.
So
Taken a biopsy, na? What histology
sir,
will suggest this likely to be a desmoid tumor? Desmoid tumors are what? These are usually a proliferation of
the spindle cells.
myofibroblast,
Yes,
more of
sir.
fibroblastic proliferation.
Yes, sir.
This can mimic some collagen which you see in keloids.
Yes, sir. So we'll have fibroblasts, spindle cells, and collagen.
It's not usually spindle cells. These are more of stellate cells.
Yes.
These are more of stellate cells and fibroblastic proliferations. There may be myxomatous degeneration. There may be some myxoid degeneration, particularly around the vessels.
Then
Okay.
so it will be non-encapsulated tumors.
Yes, these are not capsulated tumors. They are non-capsulated tumors with infiltrated local structures.
Yes, sir.
Okay, with this investigation, what is the plan for treatment in this patient? Patient has got a 7 centimeter swelling. Patient has got a lake in the abdomen. And what treatment are you going to offer for this patient?
So we can give surgical treatment to the patient or
Surgery. So if the swelling is arising on the anterior wall,
yes, sir.
involving the rectus muscle up to the posterior rectus sheath,
Yes, sir. So
and you say it's free from the skin. You say it's free from the skin.
yes,
So
sir.
if you plan surgery for this patient, what will be the then next point should be preparing the patient for surgery. So you should do other baseline investigations. Baseline investigations like hemogram, sugar, urea, creatinine. Okay. Then chest X-ray, ECG, and if required, echocardiography. So baseline investigation to assess her fitness for surgery. What surgery you are planning for this patient?
The wide local
The
excision.
principle of surgery in desmoid tumor.
The wide local
Because
excision.
pathologically said that desmoid tumors are locally aggressive.
Locally aggressive. Yes.
They infiltrate into the local. You may not see bare eye the exact microscopic invasion to the local structures. So what is the recommendation for surgery for this patient?
2 centimeter margin.
That means you need to do a wide excision.
Margin. Yes, sir. Wide local excision with a 2
So if you do a
margin.
wide excision, if you do a wide excision in this patient, this 7 centimeter lump,
yes, sir.
You are excising about 2 on this side, 2 on this side, but almost excising about 10 to 12 centimeter.
Yes, sir.
Okay.
Yes, sir.
And how are we going to manage?
So we'll do
if you excise the abdominal wall in the anterabdominal wall, taking the rectus muscle in the rectus sheath with this amount of tissue.
Yes, sir.
What is the management? How do you finish up the surgery? You have done a complete excision, taking 2 centimeter clear margin.
So we'll do a myocutaneous flap reconstruction over the defect.
Only myocutaneous flap will do, or need to do
mesh,
a mesh?
Mesh.
Yes.
Yes, mesh.
So if you do a good resection for tumor, you are excising the whole apparatus.
Yes.
So your patient will need a reconstruction with mesh and probably a myocutaneous flap. So these patients need abdominal wall reconstruction. Okay. What in the post-op period is important? You have
we will assess if there is recurrence of the tumor because it's common.
patient underwent surgery. They don't make for this patient.
Hello? The sound is not clear.
Next plan is what? Most important is patient will
Hello?
come back to you with what? Next plan is patient will be coming back to you with the histopathology report.
Yes, sir.
What? What do you like to see?
So we'll
What do you
see.
like to see in the histopathology report?
So we will.
Histopathology report will give you the details.
Yes, sir.
Histopathology report will give you the gross idea. What you have removed, what is the gross extent of the tumor, whether the
And
peripheral margin resection has
margin.
got any gross tumor or not.
Yes, sir.
Yes. And then you get a histology.
Yes, sir.
You got a histology. You discuss what are the usual histology pictures. And you can make out whether there is any microscopic tumor tissue in the cut margin.
Yes, sir.
So any positive margin on histology.
So then radiation therapy we can
No,
do.
wait. Not all patients need radiation. Radiation is not mandatory for all patients. That all depends on your histology report.
Yes, sir.
Okay. So if I say now you got a histology report which shows you have done a good adequate resection, there is no positive margin in any of these three-dimensional margins. What will you do?
But then
The patient adjuvant treatment?
we won't
Does
give the
this patient
radiation.
require adjuvant treatment with a adequate
No.
surgery being done?
No, sir, no.
What will you do?
So we will follow up the patient.
Yes. Why this patient needs close follow-up?
So because
Why these patients
high
require
recurrence
close
rate,
follow-up?
high recurrence rate of this tumor.
Yes, high local recurrence. There is higher initial local recurrence. So what
Local
will be the
recurrence.
frequency of follow-up? What will be the frequency of follow-up?
I don't know.
Most of the recurrence occur in initial 2 years.
Okay.
So the initial 2 years, patient will have follow-up at interval of 3 to 6 months.
Okay.
Following that, patient may be reviewed at interval of 1 year. Okay, for a prolonged period. So regular follow-up. And in follow-up, what do? You take a history, do a clinical examination. And if there is suspicion, you must do imaging. Now comes a situation that patient has got a positive margin. What is the strategy for a positive margin on histology?
And then we'll have to give radiation therapy.
It's a PG examination. You have to come for discussion. Does all positive margin require adjuvant radiation? You see, this is, as I said, this is not a malignant disease. It's a benign disease. So putting the patient to radiation for benign disease has some other consequences. Development of secondary malignancies and other consequences of radiation.
Yes, sir.
So what is the natural history? If you have patient with positive margins, if you follow this patient up, does all patient develop aggressive disease in subsequent period?
No, sir.
Yes.
No, sir.
No.
Not all will develop.
What should be the strategy? There comes some genetic test. You see, there is some genetic test.
Yes,
where if the patient has got mutation of these locations,
yes, sir. Teeth.
this suggests these are more aggressive disease.
Yes, sir.
In that case, you should consider adjuvant treatment.
Okay.
Okay. Is there a role for giving pre-op radiation? Is there a role for giving pre-op radiation in patient has got desmoid tumors?
No, sir.
No. It cannot be a simple answer, no. You see, I'm not talking of this patient. Is there a role for giving pre-op radiation for a patient who has got desmoid tumor? You have to read. You see, there are a lot of things in recent advances of desmoid tumor management. This is if the tumor is very large, you see, you have to do a resection. And if the tumor is so big that you are destroying the whole abdominal wall, you cannot manage.
Yes, sir. Okay,
So
sir.
if
Then,
the tumor is aggressive, large tumors, the surgery will result in a very large defect. In that case, that is a role for giving radiation therapy, number one. So, large disease, not amenable for upfront surgical resection. Radiation can cause some regression of this tumor. Second, surgery, or patient is unfit for surgery. You cannot do surgery. If the patient is unfit, patient has ECOG of 2 or 3, patient unfit for surgery. So radiation can cause some regression. It is unlikely that radiation will cause complete regression of a mass. Okay, so there is a role for radiation, but it's a benign disease. Radiation should not be given in laser indications. Any role for any other systemic therapy? You know what systemic therapy may be helpful in patient has got desmoid tumors?
yes, sir. We can use NSAIDs and tyrosine kinase inhibitors have some role.
Anything else?
Uh,
Another important group of drug may help in this. You said NSAIDs, tyrosine kinase inhibitors, and
the anti-hormonal therapy and
yes, antiestrogens.
yes, sir.
These tumors are said to be having some estrogen receptor positivity. So there are 3 groups of drugs.
Yes.
Apart from these, there are some newer drugs coming up. There are some newer drugs coming up which may help in this way. Okay. How does the antiestrogen act? What antiestrogen drug is used? What antiestrogen drugs are used? Tamoxifen.
Tamoxifen.
Okay. Some patient may benefit with tamoxifen. And dose is same as you use in breast malignancy, 20 milligram daily. What NSAIDs are used for this sort of tumors? NSAID. Indomethacin. Indomethacin is said to be effective. And tyrosine kinase inhibitors are imatinib and sorafenib. You see, these systemic therapy again is not for very distant. This systemic therapy may be helpful in situations where the tumor is large, surgery is not feasible, or you have done a surgery, that tumor is margin positive, or patient having a recurrent disease. The recurrent disease, the tumor are more aggressive. Okay.
Yes, sir.
So, you see, this is simply a short case, but your presentation should not be based on this short case. Your presentation is like an usual case. And your diagnosis should be rest on some points from history, some points from examination. You have to make important DD. And then your approach for management. Okay, clinical part you have done, imaging, histology. Then plan for treatment. Treatment may be surgery, radiotherapy, or systemic treatment. Okay?
Yes, sir.
Any question in chat box? No. Okay. If no question, you can say bye. Thank you, Aditi. Okay. Keep your presentation more wide. Huh? Don't be biased with the simple swelling itself.
Yes, sir.
You keep abdominal case. So right, whole depth of history, which will be applicable for all abdominal cases. Okay. Thank you.
Thank you, sir.